is absolutely a huge honor for me today to be podcast interviewing Dr. Daniel Klauer, DDS. I can't even say all the initials after your name. DABCP, DABDSM, DABCDSM. But as a lifelong resident of Granger, Indiana, Dr. Klauer has strong ties to the Michiana community. After attending grade school at Christ the King and going on to Marian High School, Dr. Klauer chose to pursue a Bachelor of Science degree at the University of Notre Dame. There he earned a Monogram letter as a member of the varsity golf team and proudly contributed to multiple Big East championship wins. Upon graduating from Notre Dame, Dr. Klauer chose to complete his 4 years of training at The Ohio State University, earning his doctor of dental surgery. In 2013, Dr. Klauer chose to limit his practice to treating patients with craniofacial pain, TMD, and sleep disorders due to the overwhelming need within the community. As he learned to identify the origins of patients' pain and sleep problems, it became increasingly clear that he could drastically impact their lives now and in the future. To that end, Dr. Klauer has completed nearly 2 years of postgraduate training and over 15 hours of continuing education in craniofacial pain, TMD, and sleep medicine. He is a board certified with the American Board of Dental Sleep Medicine, American Board of Craniofacial Pain, and American Board of Craniofacial Dental Sleep Medicine. He is diplomat eligible with the American Board of Orofacial Pain, and he is the only doctor in a 100-mile radius that carries these 3 board credentials. Today, Dr. Klauer enjoys educating patients and giving them tools to live healthier lives independent of medications and Band-Aid fixes. He regularly attends cutting-edge courses that further advance his clinical skills so as to continuously improve for the benefit of his patients. In his personal time, Dr. Klauer spends as much time as possible with his wife and 3 young children. He enjoys running and skiing and finds pleasure in mostly any outdoor activity. Upon meeting Dr. Klauer, you will find yourself immediately comforted by his welcoming smile, his compassion for his patients, and his commitments to providing them with the highest quality of care. If you have any questions or like to contact Dr. Klauer, please call his office 574-968-5166, or you can email him at drklauer@tmjsleepindiana. So I take it you left out the part that you must be a Hoosier.
Yeah.
And I just learned they finally found the origins of what a Hoosier really is.
Yeah, they did.
Did you hear that on National Public Radio?
Yeah, it was on NPR. It was a big deal.
Yeah, so it was the guy. So back in the day, when they would lay railroads, they'd lay 5-10 miles a day. So as you're going through town, it wouldn't make any sense to introduce everybody's name. So whoever owned the railroad, you just say he's one of his men. And sure enough, they found a person named Hoosier who laid a railroad across Indiana. So it would have been common in those times to say, I'm one of Hoosier's men. But I want to start, before we get into sleep medicine, because you're TMJ Sleep Indiana, I want to ask you a crazy question. And that is, when you're on Dental Town and you read about, say, endo or pediatric dentistry or so many of the specialties, there doesn't seem to be much disagreement or confusion or controversy. But my God, when you start talking about occlusion and TMJ, I mean, it's like 10 different religions. Why? So my question to you specifically is, why is TMJ do you agree that TMJ is probably the most controversial amongst dentists of all the areas in dentistry?
Yeah, I mean, I bet if you looked at your forums and how many times a moderator had to get involved or delete a post, I bet the TM and the sleep ones are the highest, like you said. I think that because it's in its infancy in terms of, being recognized by the dental profession and the medical profession as kind of a niche of dentistry, I think we're still in need of a lot of research and data to confirm a lot of the methodologies and protocols that are being put out, and so we're actually working on a couple studies ourselves that are hopefully lay the groundwork down so there's good data, good literature to support these techniques so that there isn't as much controversy. But the 3 phases of truth exist as always, as you know. First, your kind of disapproval, then it's met with extreme resistance, and then third, it's accepted as being self-evident. So I think as we work through the mountain hill of these TM and sleep disorders, everybody's going to come together. But yes, certainly there's all these different camps, and being rather young and in the field, the first question I get people ask, so what camp are you in? And it's kind of funny that you have to almost identify yourself with the camp when you get into these worlds.
Yeah, and so let's address that, because podcasters are generally young. Most of them are all 30 and under, okay? And so two questions they're asking me all the time. I came out of school, and I want to learn all these things, and I got to pay my bills. I'm $350,000 in student loans, and they're told they should get CAD CAM. They're told they should start placing implants. They're told TMD, TMJ, occlusion. They're told sleep. They're told Invisalign. They're told all these after graduate programs. And specifically with TMD, their specific question is, should I go to the neuromuscular camps, or should I go to the CR Pinky Dawson camp? So address why they should learn what you've learned as opposed to all the other things they can learn. And then if they do follow your footsteps, their first exact question is, should I go to like LVI, neuromuscular, test scan, electronic bite, or should I go Pinky, Dawson, Skylar, man? So is that enough questions to throw at you at once? See, my strategy is I throw 49 questions at you, hoping that one of them's good enough to bite on.
Yeah. No, I think number one is, just like anything, you got to pick what makes you tick. And so I think it's good to, in your training, in your residency, or, in your practice to, learn about procedures and different facets of dentistry, because something's really going to make you tick and other things aren't. So, there's some people that love molar endo, and there's some people that love taking out teeth. So I think as you get into the TM and sleep world, you want to, you obviously want to do no harm. So get yourself educated. And if it is something that, that you're excited, enthusiastic about, you're going to have to invest in some education. And what's great is there's a lot of different courses out there. But the number one question I get is, what was the first course you took, or what was the best course you took? And, the best course I took was with my mentor, Dr. Stephen Olmos. It's a 3-weekend mini residency. And he's done some CEs for you guys on Dental Town, I know. And that just gave you a great background for screening, doing an exam, and really evaluating these patients that come in that are kind of train wrecks. You got to get to the bottom of what's their issue in regards to pain or sleep. And so that class gives you a good background. And then after that class, then you really know enough about it to see if it's something you want to pursue part-time, full-time, 1 day a week, cases here and there, cases just for family members and patients, or you really open yourself up to be kind of the guy that people refer patients to. So it starts with a good foundational course, and I found that to be very good. Also, the American Academy of Craniofacial Pain is great, and the American Academy of Orofacial Pain, both good, reputable academies that have a lot of good information as well.
Well, you said something profound in that, a lot of times they get to the end of school and they say, well, should I go into a specialty? Would that be a good idea? And you nailed it. What do you want to do? They always say, if you do what you love, you'll never work another day in your life. So if pediatric dentistry turns you on, quit thinking about the economics of it and all that stuff. If you want to work on kids, if you want to do molar, find what flips your flipper, and you'll have a very fun, rewarding career. But you start doing things for money that you hate, it will lead to depression, disease, substance abuse, beating your children, and all those other things. You consider yourself, so you said something very interesting with Stephen, almost determining if it's pain, sleep. So is TMD and obstructive sleep apnea and migraines, is that kind of all rolled into one in your thinking?
Yeah, I think a lot of the trend is going towards, a lot of these people with chronic headaches and jaw problems, facial problems, a lot of times are often undiagnosed breathing problems. And so there's literature that's starting to support that. But I think you got to do an exam. You have to produce a reproducible, or you have to use a reproducible exam so that you don't miss stuff. So just because someone comes in and they say they have jaw pain, they may very well be a severe apneic. And if you don't have a good intake system, it'll be really, really hard to take away someone's headaches if they're suffocating repeatedly throughout the night. And vice versa. Sometimes patients come in saying they can't sleep. And if you just do a apnea exam, well, what if they do have all these jaw joint issues that are stimulating them and the pain is causing them not to sleep? You might miss the boat on it. So just kind of as a general dentist, you don't just look for cavities, you don't just look for perio, you don't just look for teeth to do implants on. You have a general comprehensive exam that screens for the areas that you have a license to treat and or refer out to. So I think a lot of times if we just do a TMJ exam or just do an apnea exam, you're going to miss the boat. And so you really need to look at these things comprehensively, just like a general dentist is looking at the mouth comprehensively.
So should a general dentist be adding your comprehensible, repeatable exam to their daily repertoire?
Yeah, absolutely. I think there's nothing more valuable than breathing. I mean, you can't argue that. You're 2 minutes and you're dead. So, really we should be evaluating patients' breathing and sleep because if we are dental physicians of the mouth or, dental medical practitioners, it's our responsibility to look past the teeth and not just look at the teeth and the gum levels, but to look at the patient as a whole. We've known Harvard did studies in the 40s that crooked teeth are a result of breathing problems. So if we see patients with crooked teeth, let's get down to the reason of why they're crooked and make the proper referral or get them the proper care because, it's what we have a license to do. And really every dentist within, you have courses on Dental Town already now that are free where you can learn how to screen someone for a TMD, TMJ, or apnea problem. And it's usually a matter of questions that you don't even have to ask. Your staff asks. And if there's enough yeses or enough nos, then you say, you know what, there might be more going on here. Great. If it's something you can do, you roll them over into that treatment room and you do an exam, or you find a practitioner in town. And, just before I got on the call with you, I met with the doctor in town. He doesn't want to make sleep appliances for his patients anymore because he wants to focus on other stuff. So he wanted to hear how I did it so he could send me his patients. And he wanted to know what he can do better to screen to send me patients. So you identify this stuff and you'll get doctors asking you how to better screen to send you patients. And it's fun because you get to help.
Can you go over so you're talking to mostly, kids under 30. Can you go over your exam, your screening exam, what you're looking at? Do you send them home with monitors? Are you do you use, just go through your exam if you don't mind.
So, when I was doing general dentistry, basically in Dentrix in our practice management system, there was a series of questions that were set up every appointment that they came in. First question was, have you ever been told to wear a CPAP? Because a lot of patients, they've been told to wear a CPAP, but they don't know what that means or why. But right away, if you have a CPAP, you have apnea or some other chronic pulmonary disease. Then we ask, do you ever take medication to fall asleep or due to headaches? A lot of times patients will say no. And then you just ask, so you don't take anything? They say, oh, I take Benadryl every night. So that's kind of a red flag. Do you have any clicking or popping in the jaw joint? Has anyone ever told you that you snore? And then the 3 hallmark sleep questions are, is it easy to fall asleep? Do you stay asleep? And do you wake rested? If the patient answers no to any one of those, then it requires further questions to figure out, okay, what's preventing them from falling asleep? What's causing them to wake up at night? And why are they not waking feeling rested? Because we are supposed to feel the best we feel in the morning, because that's right when we've recharged our batteries, got rejuvenation from our sleep, and are ready to hit the day running. And then, also just doing ranges of motion and making sure the patient can open normally, straight open and left and right, and make sure that their jaw isn't locked closed, there isn't any deflection upon opening. So in the matter of a minute, you can kind of evaluate a patient to see if they need a further workup or not. So that's kind of the screening. And you can do that in hygiene. As an endodontist, you can do it. As an oral surgeon, you do it, certainly. So really any facet of dentistry, you can ask those questions. We just have a little screening form that we have our patients fill out to do that. And then we'll pass it out to any referring dental offices that, so they can give us a better referral and have some of the boxes checked off so we know what they want us to look for.
advice I want to that I've noticed, and I want to know if you've noticed, is when I've gone to dental lectures for 30 years, and it seems like half the room is all dentists that come by themselves because they're saving money not bringing their staff, and the other half of the room is every row is a complete dental office. It's a doctor, receptionist, hygienist, assistant. Is this and it seems like the doctors who always bring all their staff, it just seems like they're twice as successful as the doctors that come all by themselves saving money. And it seems like the most successful doctors, I mean the ones crushing it, send their whole office and the doctor doesn't even go. He's out golfing while 20 people from his office are going to the course. So my question to you, is this something that your whole team is involved in? I mean, your hygienist, your assistant, your receptionist, or is this just basically with you and the patient?
It's funny you say it. Last month, I was playing in a golf tournament in town, and my staff was all in Nashville for a course.
See, exactly. Point made. I just scored. That was 40 love. I just aced you.
Yeah. So I emailed with the doctor who's taking Dr. Olmos's course coming up, and he said, "What advice can you give me to prep for it? It starts in September. I want to hit the ground running." And I said, "Bring every single staff member." And he's got a small office, 4 people, and one of them is his wife. And so bring every single staff member, because just like anything, our procedures and protocols in dentistry are really staff-driven. And if you empower your staff with all the information, it's going to make your life a lot easier. So almost always I try to bring staff or open it up to staff to come, obviously depending on what the course is. But we'll do staff retreats 3 times a year where we bring everybody together outside of the office for team building and stuff like that. But we're going to a course in November, and so all the clinical assistants and myself will be going because it's a very clinically based program. And then next weekend, my front desk staff, 4 of the 5 are going to Tennessee for a course that is just kind of the front. So I think the more time and money you put into your staff, it's just going to pay off in spades, because it's so hard to take a 16-hour course over a weekend and then to try to come back and tell your staff what you learned when you got patients lined up on Monday morning at 8 a.m. and you schedule a 1-hour lunch to give them 16 hours information. And then you start to change your systems, or you start to change what you say to patients, and the staff has no clue what you're talking about because you never told them that, oh, we're going to start using this technique, or we're going to start bonding this way. So yeah, I mean, wholeheartedly bring your staff, pay for it, and plus the staff will like it. It's time for them to get out and travel a little bit.
One of the most common questions with headaches is a lot of people say that women get 80-90% of the headaches. Is that true, and why?
Yeah, absolutely. About 70 to 80% of my practice is women. If you look at my schedule for tomorrow, there'll be 2 men to every 8 to 9 women. So there's a couple reasons to that. Physiologically, women are wired differently, so they're more their pain receptors are more sensitive. Also, they produce less testosterone, which is a wonderful pain mitigator. And so we've known for years in the pain literature that women will experience headaches more. And the incidence of TMD injuries, of TMD problems, is the same percentage as it is for women with ACL tears in orthopedic surgery. So there's definitely a connection with that and how the pain is mitigated and responded to in women. But then some things boggle my mind about women having birth, and I know men could never endure that type of pain. So
you're saying ACL tears are mostly in women too?
Oh yeah, a lot of studies. A patient that presents with TMD injuries is right at about the equivalent amount of women presenting with ACL tears as compared to men.
And explain what an ACL tear is. What's an ACL?
So of the knee joint, the anterior collateral ligament, or I don't know.
So these are showing up in women more too.
Yeah. So if you talk to orthopedic surgeons, their incidence of ACL tears is substantially more in women than in men. So the anterior cruciate ligament of the knee, the incidence of women tearing that is very similar to that of women presenting with TMD injuries. an orthopedic surgeon that I work with out of Chicago, who's my uncle. We were talking about our practices, and I threw out, majority of my patients are women, and a lot of these young females have these TMD injuries, and I showed him a study, and he goes, well, that's the same percentage that orthopedic surgeons see in young athletes with knee injuries, and so it's interesting to see the parallels between the two different specialties.
And I got an orthopedic surgeon that just lives down the street from me, and we swim a lot at Lifetime, and he says that 50-year-old swimming women and tennis players are always getting these shoulder surgeries. And if they get one side, he says you can clock down within 1 or 2 years, they'll have to do the other side. So I thought that was interesting too, because these are all very athletic women who are incredibly in shape having shoulder surgeries.
Yeah. And, part of that could be in compensation. So they hurt their right shoulder. And so now as they row, pull, do all that other stuff, they're compensating. And then once the right shoulder is good, the left shoulder is already on its way to being in harm's way. And so, we see these compensatory injuries very frequently in the jaw joint. You could have basically an osteoarthritic jaw on the right side, and the patient has no pain on the right side. All their pain's on the left side.
So in dental town, we have 51 categories, and 51 is the TMJ, TMD, sleep, all that stuff. I found a very interesting question in this category. Some people are saying, well, how can you understand sleep apnea if the patient has a comorbidity of drinking a lot before they go to bed at night? How do some of these, how many of these symptoms would go away if he didn't have 3 or 4 gin and tonics every night before he passed out?
It depends on why you're having the gin and tonic. So we know that alcohol is a sedative, and any amount of sedation will increase your apnea score, if you will, or increase the likelihood of you having apnea, because it prevents you from getting to deeper stages of sleep, and it also makes your muscle tissue more relaxed. So if you're an apneic, we know that alcohol will exacerbate that. Now, if you're drinking because your dog died and you're mentally having a hard time to unwind, the alcohol will make you fall asleep faster, but it's actually going to fragment your sleep, because after a few hours of processing that alcohol, your body's going to go through withdrawal, and that withdrawal episode actually stimulates you while you're sleeping. So it's the same reason why people can have 4 beers and they hit the pillow and they wake up at 7 a.m. with no recollection of what happened, but they feel like crap. They were just basically sedated in a light stage of sleep, and they never got into stage 3 or REM sleep, which actually gives your body that sense of rejuvenation and the energy that you typically get from sleep. So we know that alcohol fragments sleep, but it definitely can help put you to sleep. It just doesn't give you good quality.
And another thing that everybody hears in their circle, you always hear that one guy says, well, you say, what time you get up in the morning? He said, this time. It's like, wow, that's early. What, you have to be at work that early? And then say, no, I don't have to be at blah, blah, blah. And it doesn't make sense. And you say, well, why do you get up so early? And he says, well, I have to drink a whole pot of coffee before I can wake up. What would you say to that guy? Because you said earlier that when you wake up, you should feel as rested as you are, that should be as good as it feels. So what's going on if you have to wake up and drink an entire pot of coffee before you can go off to work?
My first question would be, do you like the way you feel in the morning? Say no. Would you like to feel better? Yes. Well, here, let me show you how we can help you feel better, and make it patient-driven, because if you just start to lecture the patient how it's bad to drink coffee in the morning, that's going to go nowhere fast. So just ask questions about how they feel. If they like the way they feel, if they don't, then you can definitely offer solutions. So in that case, you want to figure out what's his bedtime routine, and why isn't he getting the quality of sleep. If he has broken teeth, scalped tongue, coated tongue, dental crowding, chews the inside of his cheeks, has a lot of restorations, a lot of abfraction, narrow Mallampati score, nasal congestion. And those are all hallmark signs that it's a sleep breathing problem. So a lot of times just looking at the patient, I can mentally mark off a bunch of risk factors for apnea, and they don't even have to physically tell you them. But you always want to lead the conversation in a patient-driven manner, so you're addressing the objectives of the patient rather than just trying to prove what they have.
So let's walk them through this. You're talking to thousands of people who have probably never done any sleep study. They've never done any sleep course. You were talking first about find a mentor, Stephen Almos. Would that be your first step? Would you go listen to his 2-day course, or walk these people through? Because their questions are, where do I go? Who's going to teach me this? And then a lot of them with student loan debt are saying, am I going to have to buy like a $5,000 equipment for a take home sleep? And another thing they're asking is, well, I'm working for an old guy in associateship in Parsons, Kansas. He only has a pano machine. To do TMD, do I need a $100,000 CBCT to look at the joints? So there's 5 more questions for you.
Okay. To the cone beam one first. In my opinion, and this is again very controversial, and I'll probably get emails about it. In my opinion, I think you do TM sleep treatment better if you have a cone beam. Is it absolutely essential to have it? I would say yes, but you can do it without, and you certainly can, and there's people doing it great. I'd say most people, if you were to ask the question, do you need it for TM and sleep? Most of the no's will be from people who don't have one. So that's, you got to take that for what it's worth.
Can I throw one comment on that?
Yeah.
Over the 30 years, I've met a lot of dentists, had a lot of buyer's remorse on a lot of stuff. I've never met any dentist who saw a CBCT in which they had a pano. I haven't met one.
Yeah.
I mean, it'd be like, does anybody want to go blind? I mean, most people that can see don't want to be blind. And my God, so there's no buyer's remorse out there with CBCTs.
I just gave a symposium, and there was an attorney lecturing on cone beam. He said most of his cases now are protecting dentists who placed an implant without a cone beam, and they're losing every time because there's no excuse to be doing it without. And so I think that the radiation issue is gone. They've proven that the doses are so minimal and the technology is getting so good that I couldn't imagine working without it. So that's the answer to the cone beam question. But do you need it right away to get started? No. I mean, you can use mobile units. You can find a guy down the street who'll take the scans for you. So you don't have to have one in office, and you can get access to it. My brother-in-law does what I do, out of his practice in Chicago. He has a clinic down the street he sends all of his to, and he's going to buy one. He just, he doesn't want to break the bank right now.
And your periodontist oral surgeon wants to build a referral base. And if you call your periodontist oral surgeon, they're loving that. I mean, they're sending you cakes and cookies, and they're trying to take you to lunch. Hell yeah, they want to do your CBCTs.
And I'll gladly do it for any dentist that wants one for a patient case. I mean, I have no, the cost to run it is not an issue. So if you have a referral source that wants to get one, you get them one. I mean, you don't pay for it per use. So it's not like adding one more scan a day is going to break the bank on you or anything. You want to have protocols set up to read the images properly and make sure that from a patient standpoint, you're viewing the scans and looking at the information and not missing stuff that should be caught. You want to have a radiologist that you can send the scans to overread them and make sure that you're educated properly on it. And that's where the proper course comes in. So the proper course will show you how to identify a radiologist, how to read the scans, and when you should refer out and when you shouldn't.
My job is to guess their questions. So I know what they're asking right now in the car. They're saying, which CBCT did you buy? And what % of your scans do you have an oral radiologist? Like I said, mine to Dale Miles. What %? So which CBCT did you buy and why? And what scan should go to an oral radiologist? How much does that cost and why?
So I bought the iCat Flex. We started using the iCat Next Gen in 2011 or 2012, and it's a workhorse. I've had zero issues with it. It works fantastic. It has a great field of view. You can make it huge, you can make it small, and you can change the dosage. So the iCat has been great for us, and there's a lot of good machines out there as well. A buddy who just bought a Pro Max, he really likes it because he's doing the bite wings. He's a general dentist. So there's a ton of good ones out there. I'm partial to iCat. Scans, I use beam readers through Dr. David Hatcher, and Dr. Sharon Brooks is the oral maxillofacial radiologist that I work with. For my first 2 years, I sent every single scan I took to Sharon Brooks. So every single scan I took, I did a read on it, and then I had her read it, and then we compared. Now I probably send probably 10 to 20% of my scans to them. If there's some pathology I want clarification on, a lot of my scans go directly to an ENT though, where if I refer the patient to an ENT, which we do every day, I send the scan with the patient and the ENT reads it himself to evaluate sinus disease, nasal issues and stuff. A lot of times we'll see plaque in the carotid arteries, and internal and external, and we'll refer that over to the primary care physician, and they'll just do an ultrasound, as that's the next clinical test to do when we see that stuff. So for 2 years, every single scan.
And when are you going to be able to get Sharon Brooks to make us a Dentaltown online CE course on how to read CBCTs?
I can find, if not Sharon, I can find probably Gail Petrowski out of Toronto. She just did one for Dr. Stephen Olmos. I'll send you the link to personally so you can view it. It's free, it's online, and it's fantastic.
What's her name?
Gail. It's like Piotrowski. I could get the exact spelling for you. But she's got a great online webinar she did with Dr. Olmos that I had my staff all listen to for a good refresher, because it's great if the staff can pull up the scans, normalize them, get the TMJ selected, get everything centered and primed and ready so you can just scroll through it with the patient. It definitely increases time. And also, if they understand the anatomy when they're dictating when I'm dictating and they're scribing my notes, they know when I say concha bullosa and turbinates and all that stuff, they know exactly what I'm talking about.
So you'll email me that webinar?
Yeah, I'll email it to you. I'll write it down right now. And just like almost everything you do, it'll be free too.
Right on.
And then to answer your other question, I think question 14, what course did I take first, and what would I? So my course, like I said, I took with Dr. Stephen Olmos, and that did give me the tools to get started and feel comfortable screening, doing an exam, and delivering care. Now, by no means is one course going to give you everything you need, but I think that's a great starting point. And then his recommendation to me was to join the two academies of American Academy of Craniofacial Pain and the American Academy of Orofacial Pain and the American Academy of Dental Sleep Medicine. So he recommended I join those academies and get boarded in them. And right now I'm 3 for 4, with the only one left to take is the American Board of Orofacial Pain. So those are all good resources, and a lot of them are starting to have international chapters too. So there's a Canadian chapter, an Australian chapter, and which is nice because then we can get each other speakers across different countries and get another point of view. So I was just at a course, and Mariana Roccabato from Chile was there, and God, he's amazing, great lecturer and good information.
So is the future of TMD, TMJ, craniofacial pain going to be married with obstructive sleep apnea? Do you see these two specialties the same two sides of the same coin? Are they kind of merging together?
I think they're going to be merged together. It might take a while, but it's going to be merged together because I have so many patients that they come with TMD pain and we find out they have apnea. We have so many patients with apnea, and we take a scan and we see they have osteoarthritis of the jaw joint. So I think it's like a periodontist saying, I'll do skin grafts on the right side, but I don't do them on the left side. You really can't separate the two. It's a dentist that says he does mesial cavities, but he won't do a distal cavity prep. So I think the overlap is too much there. And you talk to guys that have been doing it for a long time, they'll say the same thing. It doesn't mean that every TMD patient has apnea and every apneic patient has TMD problems, but they're really, really hard to separate. And I think if you're just looking at one, you're going to be missing a lot on the other side.
I'm actually trying to do that in my office. I want to figure out how I can limit my practice to removing wisdom teeth, molar, endo, and just occlusal fillings, and get rid of all the interproximal ones.
Yeah.
They got to be on top or pull
Yeah.
out a wisdom teeth. An MOD composite is so much harder than an
Yeah.
occlusal.
Oh, you could, if you figure that out, let everybody know because you'd be onto something.
So what would you? So I know they're going to ask this. So what is the difference between these camps? There's so many camps. I mean, is Pinky different than Spear versus Coys versus
Yeah.
LVI neuromuscular? Are they all different, or do you see them as cross training, or what? How do you answer that question? Because the reason I'm asking is because they're very expensive. And
Yeah.
these kids are like, I don't want to fly. I don't want to buy airline tickets and stay in a resort and drop $3,000 for a weekend unless there's a really good reason.
Yeah.
And they can't when they walk out of school and they go spend an hour on all these different websites. It's help them make these decisions.
Yeah. So I feel like some of your questions are going to try to get me in trouble with my colleagues, but
It is Dentistry Uncensored.
So first of all, there's a lot of brilliant people out there teaching in all these camps. In my opinion, the differing of camps are the American Academy of Dental Sleep Medicine. Has their blinders on for sleep. They really want to ignore anything TMD. And I'm a part of that academy, and hopefully, we'll see that change. The American Academy of Oral Facial Pain, historically, and I haven't been around as long as everyone else, but in my opinion and what I've been exposed to historically has been more of the medical management type therapies for these pain conditions. So biofeedback, medications, and teaching how to manage the pain. But they are embracing sleep and having lectures about sleep and talking about more therapeutic protocols to TMD treatment. The American Academy of Craniofacial Pain has historically been more about therapeutic control of these conditions and rehabilitation to get people functioning back to normal, utilizing medications but not being dependent upon them. And them, just as the AAOP, have embraced sleep tremendously. And so both those pain academies have lectures about sleep routinely on the docket for their annual symposiums and such. So I think what you're seeing is you're going to see this merge of these academies. And I think the smarter they are, the quicker they'll merge, because together they're going to be far more powerful when it comes to insurances, specialty status, patient acceptance. If we have three people speaking the same way as opposed to three independent camps fighting over turf that is really, there's no point to fight over anymore. So from an academy standpoint, that's how I would explain those. A lot of the occlusion-based academies are are great for if you're doing full mouth rehabs and restoring, but all the current literature and Okeson's book and the definition of standard of care, it tells us that occlusal problems do not cause TMD, and I can send you slides on that where that shows that the TMD problems pre-exist the occlusal changes. So if you start by changing occlusion, you're treating below the standard of care. The standard of care dictates that reversible protocols be tried and tested and done before you even grind on a tooth. So the first step of doing an equilibration or grinding someone's occlusion is practicing below the standard of care, unless you've eliminated the TMD symptoms, reduced them, and then you proceed to phase 2 treatment. But altering the enamel is considered phase 2 treatment when you look at the definitions of standard of care.
So here's another thing that stresses me out. They hear people lecture or post on Dental Town that when someone grinds their teeth for decades, dentists would take an impression to make them a night guard. And some people say, no, they're grinding because of sleep apnea. You have to do a sleep test first. Some people see these ads for making snore guards at the lab. Other people say, no, they snore because they have sleep apnea. Is it standard of care that before you make a night guard or a snore guard that you have to have a sleep study?
G. Levy, who's probably undisputably the only thing you probably wouldn't get people to argue on is G. Levy from Montreal, or G. Levine, as people say, is the world leader in sleep-related bruxism. I don't think anybody can refute that comment. his textbook, his articles say that, and in the presence of sleep-related bruxism, it should prompt the clinician to screen for airway dysfunction or sleep-disordered breathing. So following the recommendations of the world leader, I think anybody that grinds should have a proper evaluation to determine if they are a candidate for a diagnostic sleep study. So as you know, there's never absolutes, but I think what your question was is, does someone grind need a sleep study? I think someone that grinds should have an evaluation to prove the need or to prove that there's not a need for a sleep study. A lot of grinding can be caused by movement disorders, medications, Parkinson type disorders where they could be independent of apnea. But I think grinding should always prompt the clinician to do a proper evaluation to see if a sleep test is warranted. And I'd say, a very, very high percentage of the time, you're going to find the clinical criteria to order a sleep test.
And how do you spell his name?
Its first name is Gilles.
Gilles.
And Laving or Lavigne. And he's from Montreal.
So but in the field, and reading on Dental Town, what percent of dentists do you think when they see someone abfractions, grinding their teeth, where just take an impression, make a night guard, or someone says, well, I snore, and they say, well, I can make a snore guard. What percent of the dentists do you think are doing that without a sleep study today?
98.5%.
So you're basically telling 98.5% of the dentists that they shouldn't be doing that.
No, they can be doing it, but you go to some of your forums, and I'll tag you next time I see him. You go to some of the prosthodontic forums. This guy's got his teeth worn off to the brim, his tongue scalped, and he's on 4 blood pressure meds, and no one in the forum is talking about or asking if they've treated their sleep yet. Maybe the wear of the teeth is somehow related to them suffocating at nighttime, and we know that bruxism episodes are associated with sleep transitions. So a lot of these patients, let's figure out why as we get started with the restoration, so they don't just break every tooth off and are back in our seats in 5 years wondering why they spent $60,000 on a case that just broke down. So I think when you see those signs, it should prompt the clinician to evaluate that as you get started on the workup for a full mouth rehab. The American Journal of Prosthodontics recently put out a practice parameters that, and I can send that to you, that any patient in need of a full mouth restoration or full mouth rehabilitation should be evaluated for the presence of sleep disordered breathing. So if you look at a lot of the forums on Dental Town, I'll see all these beautiful cases, and you wonder, okay, did they screen or rule out a sleep problem? Because God forbid you want to do 10 veneers and 2 weeks in, one breaks off, and now you have a color matching shade issue and an unhappy patient. And that's why most of those cases, they're put in guards because they know they still grind and they want to protect the porcelain.
Man, there's so much to talk about. So you want to talk more about sleep or TMD, or what do you want to talk about next?
Whatever you and your viewers want to talk about. I'm open to whatever.
Well, I wanted to switch to economics because a lot of the kids, like say podcasters are under 30, and they're saying, they're saying, Daniel Klauer, I have $350,000 student loans. I can't go to all these courses. I can't learn Invisalign, sleep, TMD, placing implants, buy a CEREC machine, CAD, CAM, whatever. So let's switch to economics. Let's say I have a passion for this, but can I make a living doing this? How does it work financially if I have to make a living?
Yeah, it's just like any procedure. Number one, you got to be happy doing it. If you're happy doing it, it's not a task, and you look at each problem like a new challenge that you know how to tackle. So it's like the endodontist. It's like the surgeon that loves doing wisdom teeth. You give him the hardest wisdom tooth, and he'll figure it out because he loves doing it. So once you figure out you like it, it's scalable based upon your ability to train and delegate and run through an efficient protocol. So it's definitely very can be very lucrative. Your overhead's substantially less. I remember when Tim Lott first looked at our financials, he was shocked at how low dental supplies were because really don't have a lot of supplies. We have gauze and some injection solution. Our biggest expense is lab fees, which is historically about 8 to 9% of gross collections. And that'll obviously depend on the type of orthotic and appliances you use and such. And then, staff makes up 25 to 30%. So you can operate at about a 50% overhead, if not better. Ours is a little greater than that right now. We just moved into a new building and purchased a bunch of equipment, and so on our we have some more things on our balance sheet now, and some office supplies purchases. So we put in a lot of capital improvements over the past 6 months for the build out and stuff. But my goal is to get ours right back to 50%. But I think the more you want to grow, the more you're going to have to spend, and so it'll be well worth it to dip into the marketing budget a little bit more and spend on that.
Now you're in Granger, Indiana. Is that a suburb of Indianapolis, or is that
we're right on the Michigan Indiana border, right next to South Bend, which is where Notre Dame is. So my office is 2 miles away from Notre Dame, right on I-80. South Bend is a town of about 100,000 people. Notre Dame is 8,000 students. Indiana University has a branch up here that's actually bigger student body than Notre Dame is. And so we're just a town, blue collar town of about 100,000 people. And honestly, if there was 2 or 3 more people like me in the area, we'd all stay busy. So there's no shortage of patients. I mean, 30% of the population has apnea has apnea or some breathing problem that needs treated. And studies show TMD is 18 to 28% of the population has a symptom of TMD. So there's no shortage of patients.
Another question they're having along the lines of economics is, am I going to have to buy like a several $1,000 piece of equipment to send them home to a sleep study, or do I send them out to have a sleep study done? Do you send your patients out, or do you send them home with your own device? And how much money was that? Go into that, please.
So, step one is, no, you don't need to buy one to start. To start, you need to know how to order it and then get a direct line to a physician or a lab that you can order at, so that a patient doesn't have to see another doctor, and then get another test. So step one is identify some people in town that you can refer patients to. And it's so easy to pick up the phone and say, hey, I want to send you patients. Can we meet? I think only an idiot would say no to that. So that's your first step. Then once you get that going, if you're going to start delivering care, you do want a home sleep test screening system in your office. The good thing is that those range in price. I'm partial to the Metabyte. We use that. We have 3 of them, and they work fantastic. They're anywhere from $2,500 to $5,000 depending on the device you get. What's great about the Metabyte is it's less than $5 per use. So once you purchase it, you're only spending $5 to run a test. Now you can charge the patient, you cannot charge the patient, you can lump it into your fee, however you want to do it. But that's one of those where it pays to get a good unit, because I've had my oldest one going on 3 years now. We've never had an issue with it. It works on a rechargeable battery that you just have to replace that battery every 3 to 6 months for, I don't know, $20 or something. And so that's great. So it's scalable. Once you start doing more cases, you want to buy a unit and get it, but you don't need it to start.
So Metabyte's made by Braebon?
Yeah, Braebon. Mm-hmm.
So go to Braebon.com, Braebon. Braebon just pretty much only does sleep, right? All their products are sleep related?
All their products are sleep. The co-founders of that developed the first computerized polysomnogram. Polysomnogram is the professional term for a sleep study in lab. The owners of Braebon started the first computerized way of tracking all the sleep data, and it was called Sandman. And so basically they developed this home sleep testing system. And they have a lot of online webinars too that are great, interviewing sleep doctors and dentists and stuff. So just like you, they put out a lot of good quality information for people that are hungry for it. So Braebon has a great system that has really just been a great resource for our practice. They even send us these posters. I could show you. They're in all of our treatment rooms. that help screen for apnea. I'll show it to you real quick, Howard. So you just email them, and they'll mail you down this big poster. And
Braybon will?
yeah, right there.
Oh, nice.
And so it has all the risk factors right here.
They send you that for free?
Yeah, yeah. So
Snoring is an alarm telling you something is wrong with your breathing. Nice. So do you have one of those in your waiting room or in different operatories?
Yeah.
Or
We have it in each. So that's one operatory. I'll walk to the next one. We have one in each operatory for patients to look at. And if they think they're here for TMD problems, then they'll look at that and say, oh, but I've had a stroke. I have depression. I wet the bed as a kid. I have erectile dysfunction, whatever it might be. They'll say that out loud to us, and then we know what's going on. There's our ICAT. So,
the erectile dysfunction that you just said brings up a lot of questions that this morning when I was working out, a lot of physician people are saying the same thing about ED and high blood pressure.
yeah.
And you could say about snoring. They're saying that people go to the doctor and they have erectile dysfunction and they just give them a pill. And
Yep.
they're saying that they're starting to look at studies saying, well, first you should figure out, why do you have erectile dysfunction? I mean, probably got obesity, diabetes, pulmonary issues, smoking, all this stuff. And giving some guy an ED pill is not the way to treat it. And some people, have you read that book, The K Factor,
No.
by an MD and a PhD, saying that when you lower someone's blood pressure with a pill, he doesn't see the change in morbidity. But if you lower your blood pressure because you lost weight, diet, exercise, and get healthy, you don't need the pill, but then you increase, you decrease your morbidity.
Yep.
And some people are saying that about snoring, that if you treat the sound with a Snore Guard, are you really treating obstructive sleep apnea? And that's my question to you. Is treating snoring with a Snore Guard like treating high blood pressure with a pill or ED with Viagra?
No, I think treating snoring with earplugs, is the version of a pill, in my opinion.
But but that works, especially if you do it with coconut oil swishing.
Well, it can.
If you do it with coconut oil pulling and earplugs, you don't even need to go to the dentist, do you?
Well, it's one of those. You made a good point. If it's like a patient, you just doing 5 cavities and never talking to them about why they have it, that's like being a carpenter and just patching it. It's like, what good are you doing the patient? They're just going to get more recurrent decay around those fillings if they don't change their habits. So, I think that with snoring, number one, the guidelines tell us you can't treat snoring unless you've done a sleep study to prove that apnea doesn't exist. So if you've proven that apnea doesn't exist and you make a patient a Snore Guard, you are doing them benefit. There's a study done on a couple thousand women showing that snoring alone, not apnea, snoring alone increases the risk for cardiovascular disease in women. So we know that snoring, like that poster says, is an alarm, and you do want to treat it, and you want to treat it organically or naturally if you can, and not just muffle the sound, but actually make sure that enough air is getting into the system, into your airway, so you don't have the reverberations and you're not getting the oxygen desaturations. So that's why I'd say if I snore and my wife treats my snoring by just wearing earplugs, that doesn't do me any good. But I think if you wear an appliance, improve your nasal patency, get your deviated septum fixed, and you actually eliminate the snoring.
Oh, when you said earplugs, you meant that for the spouse? Or because on the internet, there's people treating TMD with earplugs.
Oh, yeah, they're just putting some pressure on the posterior joint space.
Have you seen that?
Yeah, they come by the office to pitch it to you and stuff.
What do you think about that?
They're close. I mean, if the ear pain's being caused by inflammation in the posterior joint space that's pushing into the ear, it's close. But again, get to the origin of the problem. Don't just give a pill for high blood pressure. Figure out why. Does diet need to change? Does lifestyle need to change to get the origin of the problem? Because you're always going to have longer lasting relief that's beneficial. And so, all of our ENT friends, if someone comes in with ear pain and there's nothing wrong with the ear, they send them right over to us because they know it's referred pain from the TM joint. So, I think at heart as practitioners, we want to figure out the why. And so I think we just need to keep asking ourselves that question as we evaluate these patients and come up with a game plan to get them feeling better.
You are a world of information. When are you going to create a course on Dental Town?
Oh, Hogo just sent me the paperwork, and I just got to get to work now.
Oh man, I'll tell you what, we those courses ever since we put them on the iPhone,
Yeah.
they've gone crazy.
Well, I'm hoping to have it done by October. I got a lot of stuff in between now and then. My first course, actually, so I signed up for Dr. Olmos's course, and I thought, hell, I need to get going. So I took Dr. Olmos's course on TM and sleep that you guys have. I took Barry's course on TM and on sleep, and then I took
Barry Friedberg?
No, Barry Glassman. Yeah, and so I guess my first course, I signed up for Dr. Olmos's, but then my first course was actually Dental Town. So I can give you props for that. And so Hogo had just sent me the paperwork, and we're going to do it on the business side of TM and sleep.
Hogo gets all the credit for that. I don't get any of that credit. He's got.
You emailed me, and then I emailed Hogo. So
I said I referred you to Hogo.
Yeah.
Yeah, he's so great because he turns down most offers of DCE because he really tries to get a feel of what the whole town thinks about the information before he puts it up. Yeah. And he's got what, I don't know, 350 courses up, but I bet he's turned down 1,500.
But yeah, he told me to suggest topics. I gave him 3, and he took the 3rd. Yeah. So because there's enough on TM, there's enough on sleep. He wanted to see, okay, how does a practitioner make it work? So what I'm going to go through is on the financial side, when I purchase the things, some systems, how we look at some of our financials and stuff like that, just so people know that you can make a living doing it, you can do it full time, and it's really operates just like a general dentist, an endodontist, an oral surgeon. It you can make it work either way. So.
And the proof is in the pudding. There's now in most states dentists doing this full time, not doing anything else. I mean,
yeah,
only doing that. Mm-hmm. I want to ask you. It seems to me that this is really in the public's face. I mean, if you read much magazines, spend much time on social media, sleep. I've been a dentist for 30 years. I never heard a thing about this the first 20. I heard a little bit about it 10 years ago. But 5 years ago, it started really getting mainstream, and now it just seems like the B2C market, not B2B, the B2C market. And Arianna Huffington's book is cruising on the top of the New York Times about sleep, and she owns the Huffington Post. So the Huffington Post, because she owns it, is just doing so many articles on this. But I want to ask you this: for you to be full time, what % of your patients are B2B, sent by referring dental businesses, dental offices, versus B2C, where a consumer just comes to you?
Yeah. So it's funny you asked that. So before May 6th, I was in a general practice office. And so I had a lot of referrals from that dentist in my office because he knew what we did. He knew we were close and everything. But general dentists would not refer to me until I got out into my own independent office. And I think that just came from, another dentist was in the building. They didn't want to refer to me. So right now it's changed, and about 1/3 of my patients come from dentists, 1/3 come from physicians, and 1/3 come from online Google, outside source. Now those numbers change each month by 5 to 10%. But if I were to, make a generalization, it would be that. I'm getting referrals from cardiologists, urologists, ENTs, primary care docs, and then orthodontists, oral surgeons, endodontists, general dentists. And then I probably, the internet is always teetering more towards the top, just from, hey, I went and saw this doc, and I found you online. I saw the testimonials of your patients online. I listened to a webinar you gave online, and so I think that number one, you got to have a good social media presence so that people know you exist. Because we have patients too that will say, oh, I asked my dentist about you. And so then he referred me over. So yeah, the dentist sent him over, but the patient said to the dentist, hey, Dr. Farran, what's this Klauer guy about? My jaw hurts. Can I go see him? Oh yeah, I'll send you over there. And so a lot of our referrals are like that too.
And how did you get your name out to physicians?
I first started, any patient that came in, we'd ask them their physician, and then I'd write a letter to the physician, and then I called them. I had time, so I called them and I waited on hold, and I said, hey, hey, Dr. Howard, Daniel Klauer, I'm a dentist. I only treat people with pain and sleep problems. I saw your patient, Mrs. Jones. I just want to let you know I'm going to refer for a sleep study because I saw X, Y, and Z. You're going to get a letter from my office, but if you have any questions, just let me know. And usually they go, oh, okay, well, thanks for calling. Bye. And so when they got my fax with my letterhead and they saw my name, and then it kind of turned into a patient who couldn't tolerate a CPAP, the primary care would send them over because I took the time to, get them on the line, tell them what I did. And then we always try to make appointments to go see them at the office. Sometimes that doesn't work. So you can always call the doctor's office and leave him a message with the nurse, or just wait till he gets out of a room and give him a quick on the phone update about his patient. Chances are he won't even pull the patient's chart to see who you're talking about, but he just knows that you care, you're doing a good exam, and then he'll use you as a resource when he has patients that need it.
Nice. Very nice. That's a hell of a marketing tip. You want to know one of the marketing tips I did when I was little and got out of school? I loved the toothaches. I wanted to
Oh, yeah.
do a
Yeah.
root canal or pull a tooth. That's what I loved the most. I restored dentistry, little fillings and crowns and hygiene checks and everything. Well, it was fun to
Yeah.
to see the patient, but it wasn't like a root canal or an extraction. So so I used to always make up a bunch of referral pads back when they were pads. Now they're all digital, and I'd drive to all the Walgreens and CVS's, and I'd walk in there and tell the pharmacist that, hey, do people ever ask you what's good for a toothache, like aspirin, Tylenol, or any of this stuff? And they'd say, yeah, and I'd say, well, tell them this is what's best for a toothache, and I gave them my prescription pad. I've
Yeah.
always had a dozen pharmacists referring me toothaches.
That's awesome. I was going to show you, we made a referral pad similar to give to the dentist. Yeah, that one. And so same thing, we'll give that to the dentist.
Nice. Have you posted that on Dental Town?
I have not. I can.
Would you mind?
Yeah, no. Yeah, I can post it.
So
And-
so it's the last form in dentistry. It's TMD, sleep apnea.
Yeah, I've been on it. Scroll all the way to the bottom to get there.
Yeah. And I want to thank you for your gazillions of posts that you've made. I mean, you've been posting for a decade, since 2006 to 2016. I'm a huge fan of your post. I'm supposed Hogo didn't send you before me, but really, seriously, I mean, thank you so much for all that you've done on Dental Town, for all the posts you made, all the questions you've sent in, and all that kind of stuff. That's amazing.
No, my pleasure. It's a great resource, and it's fun to always look at and keep up to date with what's going on out there.
So my homies can be expecting to see a course from you soon.
Yep, hopefully by October. Now that I told 30,000 people, I got to make sure it gets done by October.
And then my last question is, how come Ohio State University is the only university where you have to put a "the" in front of it? Why is it the Ohio State University?
It's actually the Ohio State.
It's it's not the, it's the.
The. It goes back in the day. Ohio State was the first state school, and it went by Ohio. It went by Ohio University, and then later Ohio. It was always Ohio State University on paper, but people called it Ohio or Ohio University. Well, back a few years after, Ohio University, the school down in oh God, my wife would kill me for not knowing where, but became mainstream and became a school for people to go to. So they had to differentiate Ohio State versus Ohio University. So the ostentatious people of the Buckeyes, they started to call it the Ohio State University rather than Ohio University. So it gives it the extra distinction.
That's what it is. I always wondered. Well, hey, Daniel, thank you so much again for spending an hour of your life with me and my homies. Thank you for being a townie for a decade and all the posts. thank you so much for making a course coming up. I think what you're doing is so amazing, and I think you helped a lot of people decide if this is something they want to learn more of.
Awesome. Yeah, I'll email you that info and look forward to staying in touch.
All right, and last question: did you read Arianna Huffington's book?
I have not. I have not. I
It
wrote it down. I wrote it down here and the K factor.
Yeah, she is
Both
a.
on my Amazon.
It seems like I don't know how old she is. She's probably my age, 53 or whatever. But she's an incredibly famous person, and I mean she is putting out so many studies. I mean she had a lot of examples, even including Bill Clinton. I mean just a lot of deals, but a lot of I've noticed a lot of people in their 50s and 60s and 70s are asking me about that book. So you'll probably have consumers,
I
patients
got
asking.
one. I got one for you. I just finished reading. The Oxygen Advantage. Look it up. It's good by Patrick McEwen.
And what's
It's
that about?
all about breathing and all the natural stuff that we've forgotten about breathing that we've known for thousands of years. Just it's real simple, just about breathing and how if we address breathing, a lot of the issues that we face as a society will improve dramatically. So it's a good book. It's good for a doctor and it's good for a consumer.
And you know what other breathing questions I'm getting asked a lot by patients and friends and all that stuff is that if they to perform better in their marathons and
Yeah,
running. I live in Phoenix. They say, well, if I go up to 7,000 feet at Flagstaff and spend the night there the night before my marathon, will I run faster? I had a lady ask me at Lifetime Fitness the other day. She goes, I'm thinking about buying an oxygen tent, but my husband doesn't want me to because it's $10,000. But I told him, I want to score. You got to be in. They want to score in their age range. It's every 5 years for marathon, and they to medal they got to be
yeah.
in the five in their age range. They say I'm always 6 or 7, but do you think if I bought an oxygen tent, I'd be more likely to win? I mean, so yeah, so it's really getting very very common.
You can tell them to buy this book because this book actually talks about that exact thing. How to experience high altitude training at sea level. And so the author of this book actually trained for Notre Dame track and field runners that are now competing in the Olympics. So here in South Bend, he stimulated high altitude training through breathing exercises. So like when I go on runs, I'll either tape my lips closed or keep my lips closed the entire time and just breathe nasally. So this book gives you the exercises so you don't have to buy a $10,000 oxygen tent.
So well,
And
to talk more about it, there's a lot of people. So keep going, keep running. What did you learn? So breathing by your nose stimulates high altitude training.
yeah, well, there's different ways to do it. So basically, breathing through your nose is how we're supposed to breathe. We're supposed to eat through our mouth, breathe through our nose. When you breathe through your nose, the air passes over the turbinates, and nitric oxide from your sinuses dumps into the air, and it increases the carrying capacity of oxygen. So breathing through your nose is a surefire way to get more oxygen to your tissue. So when you mouth breathe, you're breathing in cold, dry, dirty air, and you're going to get more muscle fatigue and get out of breath faster because you're hyperventilating. You're expelling too much carbon dioxide. Carbon dioxide levels internally is what causes our oxygen to get dispersed out into the tissue. So we need to keep a good level of carbon dioxide inside of our body so that oxygen gets out into the muscle tissue. So if we overexpel, hyperventilate, mouth breathe too much, we're just taking in more oxygen isn't the answer. We have to have carbon dioxide reservoir inside of our body so that the blood, the muscle tissue and all of our fascia gets oxygenated. So when you breathe nasally, you maintain those carbon dioxide levels and you're actually getting more oxygen throughout your tissue. So if you go on a run, a lot of people can't do it, but if you work up to being able to breathe through your nose, those points where you have to overexert and really push it, you'll be able to because your body's not going to get as fatigued. So you look at the marathon runners, the Kenyans and those people, they're usually breathing in through their nose, out through their mouth, in through their nose, out through their mouth. And they're breathing nasally the whole time, even though they're on mile 25 or whatever. So the book talks about, part one is about the physiology behind it. So all the stuff that you and I would want to know. Part two is all the people that at the gym want to know. All right, just tell me the exercises to do. I trust that you know what you're talking about. and let's prove it to me that this is going to increase my performance. And so it goes through exercises of how to train yourself during the day and even while you're working out, and how to test your parameters, and so that you're not over breathing, but you're breathing efficiently, and keeping the oxygen levels of your tissue as high as possible.
But a lot of people always point out that Kenya is a mile high, like Denver, and all the marathons around the world are usually big cities next to the ocean, like New York, London, and so they're all training at a mile high, and all the races are at sea level, and that's a big part of their
Yeah.
success.
They also most likely they haven't been exposed to as heavily processed foods as we have. They probably all have all 32 teeth, big broad arches, and don't have these collapsed arches with midfacial deficiencies that also help them breathe better. So yeah, there's a ton that goes into it. You've probably seen it in your practice. I've seen it when I was doing general dentistry. There's an older brother, 70-year-old guy I'm treating, never had braces, never had a cavity in his life. His younger brother has a collapsed arch, cavities and crowns everywhere. And the only difference was older brother grew up on the farm, the family moved to the city, and diets completely changed, lifestyle completely changed, and now the whole facial development's different. So there's a lot that goes into it. The breathing training at high altitude is certainly one, but you can also look at the other environmental factors that they were exposed to as they were growing and developing.
It's amazing how all the doctors now are, every doctor you go to is starting to come out of their little silo where they
Yeah.
used to be just one thing, and now they're starting to look at all the interconnected parts.
We've seen it shift. If you look at doctors who practiced in the 40s and 50s, they had to cover everything. And then we're getting so specialized and narrow, and it's going to have to come back out, because just like everything was connected early on in medicine, it's still connected, but we got so hyper specialized that, an endodontist is just looking at the pulp of the teeth and not looking at, the masseter muscle or the temporalis muscle can refer pain to that tooth too. And all of a sudden we miss and we do a root canal when it's not needed, or take a tooth out when it's not needed and it was referred pain. So I think hopefully we get doctors to start looking more, take off their blinders, which as you're saying is happening, which is a good thing.
And you know what I used to tell my oral surgeon that I had to do, or I wouldn't refer to him, and I changed oral surgeons over it, is you'd send him to an oral surgeon, they just pull out the 4 wisdom teeth, max out the insurance, 1,000 for the year, and it was done. But I would fax over the treatment plan, and if he would just look at that, look at the x-rays, and then confirm and say, by the way, Daniel, you have 4 cavities, and you need to go back to Howard and get these 4 cavities done, or you may be coming back here in a year or two to get 4 more teeth extracted, or have root canals or crowns or whatever. But make sure you go back and get those 4 cavities. And just the specialist going over the treatment plan that I was going to do increased the case acceptance so high, I didn't care what the referring dental specialist was doing, just because they were reviewing the treatment plan.
No, I think that's huge. I get to be the good guy with someone comes in for a sleep appliance. They got a huge amalgam on number 15 that I know in my head, I know that the dentist has been telling them they need a crown on it. And I just say, great, we're going to get this sleep appliance done. We're going to make you feel better, sleep better. Your ED is going to go away, whatever it might be. But I need you to get that crown done first. They call the office, they get that crown done, and the dentist will call and say, I had a watch on that for 6 years, and I've repaired it 4 times, and he wouldn't let me crown it. Thanks. And so, yeah, I mean that's huge when you're in a business of fostering relationships with local providers. It helps.
Well, hey, man, we went into double overtime. Daniel, thank you so much for doing this with me. Thank you for all that you do for dentistry, for Dental Town.
My pleasure. We'll be in touch.
Okay, buddy, have a rocking hot day.
All right, you too. See ya.